Hi, I'm Scott Beach. I'm the program director at the MGH McLean Adult Psychiatry Residency Program, and I'm a psychiatrist on the Acute Psychiatric and Consultation Liaison Services at the Massachusetts General Hospital. Today I'm going to be talking about the management of delirium. Before we get started with management, I think it's important to talk a little bit about the concept of delirium and what we mean by it. One of the key principles that I always start with is thinking about delirium as a syndrome rather than a specific diagnosis. It is, of course, a specific diagnosis. It's in the DSM-5, but I think it's really helpful to think about it as a constellation of symptoms, all of which are suggestive of global brain dysfunction. And delirium has many potential etiologies and many potential manifestations. There have been several mnemonics over the years that have proposed to list all of the potential etiologies of delirium, but I find a better rule of thumb is just to say that anything that can cause either a medical or a surgical problem can also cause delirium. With regards to the pathophysiology, we used to think about a very simplified version of delirium, which represented an imbalance of dopamine and acetylcholine, such that there was a relative deficit of acetylcholine and a relative excess of dopamine. We now understand that delirium is a very complex mechanism that likely involves neuroinflammation, neuronal aging, oxidative stress, neuroendocrine dysregulation, and circadian dysregulation, all of which contribute to the syndrome. Importantly, delirium is also vastly underdetected across clinical settings, with up to 86% of cases of delirium missed by providers. The DSM-5 definition of delirium requires a disturbance in attention and awareness. So by definition, patients with delirium are inattentive. Importantly, the disturbance develops over a short period of time, usually hours to days, represents a change from baseline, and tends to fluctuate in severity during the course of the day. And this fluctuation is often referred to as waxing and waning. An additional disturbance in cognition is required for the diagnosis of delirium, though this disturbance can occur in one of many domains. These include memory deficits, disorientation, language deficits, visuospatial deficits, or perceptual disturbances. The disturbance of delirium is a direct physiologic consequence of another medical condition. So by definition, it's caused by a medical or a surgical issue. And like many things in the DSM-5, it's not better explained by another syndrome. When it comes to risk factors for delirium, we can broadly divide risk factors into non-modifiable and modifiable risk factors. Among the most important non-modifiable risk factors for delirium is age. And a good rule of thumb is the older somebody is, the more likely they are to be delirious. Another really important non-modifiable risk factor for delirium is medical conditions. And a second good rule of thumb is that the sicker somebody is, the more likely they are to be delirious. We can think about this in a number of different ways. We can think about it by where the patient is at the time. Somebody in the ICU is more likely to be delirious than somebody who's on the medicine ward, who's more likely to be delirious than somebody in an outpatient clinic. We can also think about this in terms of the number of active medical issues or even the length of the past medical history, with longer sections in the documentation conveying a higher risk for delirium. A third really important rule of thumb is that any process that affects the brain increases the risk for delirium. And we sometimes refer to this as having a vulnerable substrate. Among the many conditions that convey a vulnerable substrate are things like dementias, cerebrovascular accidents or strokes, inflammatory processes, space-occupying lesions, or traumatic brain injuries. And a final non-modifiable risk factor for delirium is inflammatory states. We know that in particular, states in which there are large amounts of systemic inflammation are a setup for delirium. These may include long bone fractures, burns, or complex surgeries like a AAA repair. But it's important to keep in mind that even low-level infections like UTIs can cause delirium in patients with a vulnerable substrate. Among the modifiable risk factors for delirium, the things which we as physicians can actually intervene upon, probably the most important is medications. And while there are many medications that are associated with increasing the risk for delirium, primary among those are anticholinergic medications, benzodiazepines, and opioids. Another really important modifiable risk factor for delirium, of which many providers are unaware, is immobility. Anything that can be done to mobilize patients who are at risk for delirium can actually decrease their chances of becoming delirious. Something as simple as moving a patient from the bed to a chair a few times during the day actually decreases their risk for delirium. Other modifiable risk factors include metabolic disturbances and poor oxygenation states. If we think about how delirium manifests, we can divide delirium into different motoric subtypes. We often picture the hyperactive delirious patient, the patient who's agitated, awake at night with hypervigilance, sometimes wandering, kicking and screaming. In those patients, perceptual disturbances may be more common, and patients with a hyperactive delirium are often confused with mania, schizophrenia, or anxiety. Even though this is the form that we tend to picture, it turns out it's actually the least common form of delirium. Much more common is the hypoactive subtype, where patients display psychomotor retardation, apathy, slowed speech, and decreased alertness. This subtype is often confused with depression, and it's very underdiagnosed, despite being the most prevalent at up to 80% of delirious patients. Finally, there's a subtype sort of in the middle that is called a mixed subtype, where patients may alternate between hypoactive and hyperactive features. So to wrap up this section, key points include the idea that delirium is a syndrome rather than a specific diagnosis. There are 3 motoric subtypes of delirium: hypoactive, hyperactive, and mixed. When we are assessing somebody who may be delirious, it's important to keep in mind that delirium is a bedside diagnosis, meaning there are no blood tests or imaging studies that will confirm the diagnosis. So we have to rely on history. In particular, we want to look at the pattern of onset and the progression of symptoms, and we want to look for an abrupt onset and again for that waxing and waning quality. It's important to keep in mind that patients who are delirious are often poor historians, so we generally rely on family or other staff. It turns out that in the hospital, nurses, physical therapists, and occupational therapists are the best at diagnosing delirium because they tend to spend longer amounts of time with patients and often engage them in tasks requiring executive functioning. If you're really unsure about whether somebody is delirious, an electroencephalogram can help confirm the diagnosis. The classic EEG pattern in delirium is one of diffuse background slowing, so showing predominantly delta theta waves. Importantly, the EEG will actually be normal or even fast if the delirium is due to GABA withdrawal, like in the case of alcohol or benzodiazepine withdrawal, but that is the only cause of delirium that will give you a different EEG pattern than the typical diffuse background slowing. A neurological exam is an important component of the workup for delirium. There are no findings that are pathognomonic, but several findings are suggestive of global brain dysfunction. It's been said that a multifocal myoclonus is perhaps the most common neurological feature in delirious patients, so you should be on the lookout for patients displaying non-rhythmic muscle jerks or muscle twitches distributed throughout various muscle groups. Remember, too, that frontal release signs may return in patients who are delirious, likely due to involvement of the frontal lobes. These frontal release signs can include things like the Babinski or the grasp reflex, but you may also test for other frontal release signs like the glabellar sign or the palmomental reflex. The cognitive exam is a really important part of any workup for delirium. Of all the different cognitive dysfunctions that may be present in delirium, executive dysfunction is the most common manifestation. This again has to do with the fact that delirium has a predilection for the frontal lobes. Disorientation is also common, but it's really important to keep in mind that some delirious patients will be intermittently oriented, and a small minority may actually remain oriented throughout the course. So intact orientation does not rule out delirium. Short-term and working memory are often impaired, whereas long-term memory is generally intact. Language deficits can be present in delirium and may include word-finding difficulties and paraphasic errors. Visual spatial deficits, however, are pretty uncommon in delirium. Recommended testing for delirium includes starting with orientation, but also including months of the year backwards as a test of working memory, attention, and set, as well as either the clock draw or the Loria sequence, both of which are great tests of executive function and allow for serial exams. Though we have standardized cognitive tests like the Montreal Cognitive Assessment Tool, the MoCA, or the Mini Mental State Exam, it's important to keep in mind that many delirious patients will not attend to a 30-point questionnaire. Among other entities on the differential diagnosis for delirium, first and foremost, it's important to rule out other neurocognitive disorders like dementia and traumatic brain injury. These can often be distinguished by paying attention to their speed of onset and the fluctuation of the mental status throughout the day. If somebody has a relatively rapid onset of mental status changes, dementia is an unlikely diagnosis. Serial cognitive testing may also be useful. The clock draw done once may not help you distinguish delirium from dementia, but done several times a day over the course of several days is likely to help make that distinction. Another key thing on the differential diagnosis is depression and demoralization, particularly if the delirium is of the hypoactive variety. While depression may cause pseudodementia in rare cases, the onset is not usually abrupt. Other neurovegetative symptoms are typically prominent, and the mental status does not tend to fluctuate. Patients with a hyperactive delirium may look like patients with mania or schizophrenia due to their agitation and their perceptual disturbances. However, keep in mind that cognitive deficits are not typically prominent in mania or schizophrenia, and again, the symptoms do not wax and wane over the course of the day. So why do we care so much about diagnosing delirium? Why is that important? Well, it turns out that delirium has significant consequences in terms of both morbidity and mortality. The 3-year mortality for hospitalized elderly patients with an index episode of delirium is 75% as compared to 50% for non-delirious controls. And delirious patients may experience an adjusted risk of death of almost twofold compared to non-delirious controls. Increased morbidity is also prominent, with patients displaying poor functional recovery and an increased risk of medical complications. Most importantly, delirious patients also have an increased risk of future cognitive decline, which may occur in up to 40% of delirious patients, and that includes an increased risk of dementia. Some patients never really recover for the delirium and basically develop a dementia. Increased nursing home placement and increased length of stay is also a consequence of delirium. Furthermore, there are many sequelae of delirium, and this becomes particularly important when we think about the possibility of managing delirium with medications. We think often of agitation as a major sequelae of delirium. Agitation increases the risk of harm to the patient and the staff. Patients may pull out IVs, they may rip at central lines, they may fall out of bed, and they may log assaults on nursing staff and other hospital workers. Furthermore, patients with delirium are at risk for perceptual disturbances, things like hallucinations and delusions, and those perceptual disturbances greatly increase the risk for post-delirium PTSD. This is now a well-described phenomenon, which itself is probably very underdiagnosed, but is incredibly distressing to patients who have suffered from an episode of delirium. So to wrap up this section, the consequences of delirium include increased mortality and morbidity. The sequelae of delirium include agitation and perceptual disturbances. The differential diagnosis of delirium is broad and includes other neurocognitive disorders, depression, mania, and schizophrenia. The diagnosis of delirium should be made at the bedside, relies primarily on history and course of illness, and may also benefit from a good neurologic exam and cognitive testing. In this section, we'll talk about potential strategies to prevent delirium. And that's really one of 3 main questions that we want to address today. Can we prevent delirium with medications? Can we treat delirium with medications? And can we manage delirium with medications? So let's start with prevention. In terms of preventative strategies, one of the most important things to think about has to do with the choice of analgesia and sedation. We know that compared with midazolam, patients who receive dexmedetomidine for postoperative mechanical ventilation sedation have a lower risk of developing delirium. For any patient who may be at risk for delirium, we would therefore recommend at least considering the use of dexmedetomidine as a way to mitigate that risk. Among opioids, Dilaudid and oxycodone may be associated with lower rates of delirium than morphine. So here again, if you have a choice in terms of analgesic medications, you may want to go to a medication that has a lower risk of causing delirium, like Dilaudid or oxycodone. Overall, the evidence base for preventing delirium using medications is somewhat mixed. There is some evidence that melatonin and melatonin agonists like Ramelteon may help to prevent delirium, though the data is not particularly robust. There's also mixed data when it comes to prophylactic use of antipsychotics to prevent delirium, and this recommendation is not currently supported by the literature. Though a few studies have suggested reduced rates of delirium when patients are prophylactically given antipsychotics, this has not borne out in many larger studies and is therefore not recommended as general practice at this time. If we look at individual studies that have assessed antipsychotics for the prevention of delirium, a few of the ones with positive results have used prophylactic haloperidol at a 5 milligram dose, resulting in a reduced incidence of post-op delirium, or intravenous haloperidol in a 0.5 milligram bolus and then given Q12 hours for surgical patients, showing a reduced incidence of delirium as compared to placebo, with a longer time of onset to delirium, lower mean number of delirium-free days, and a shorter ICU length of stay. However, in hip replacement surgery, prophylactic haloperidol of 1.5 milligrams daily started pre-op and continued 3 days post-op did not reduce the incidence of delirium. Similarly, in a study looking at intravenous haloperidol of 2.5 milligrams every 8 hours as compared to placebo for sepsis and ARDS ventilated patients, the two groups had a similar number of days of delirium, days in coma, and days alive. However, a significantly lower number of patients in the haloperidol group had a RASS score of greater than 2, which does suggest some reduction in agitation. Other studies have continued to show mixed results in different populations using IV haloperidol as well as other antipsychotics. And a 2019 network meta-analysis actually found that Ramelteon was the most effective of all agents at preventing delirium. So, as take-home points, there may be some important strategies for choosing your analgesia and sedation that could reduce the rates of delirium, including thinking about using dexmedetomidine, particularly in older patients who are at higher risk for delirium, considering the use of opioids like oxycodone and Dilaudid rather than morphine, and considering the use of melatonin or melatonin agonists. However, there is no evidence to suggest that prophylactic use of antipsychotics should be routine and results in lower rates of delirium. The second important question that we want to ask ourselves is, do medications, particularly antipsychotic medications, treat delirium? And in this context, I want to make a really important distinction between treatment and management. When I use the term treatment, I'm indicating a reversing of the delirium or shortening of the length of the delirium episode. Later, I'll use the term management to refer to mitigating sequelae of delirium, such as agitation and perceptual disturbances. Currently, many physicians believe that antipsychotics may treat delirium. In fact, 65% of intensivists worldwide and 48% of those in the United States reported using haloperidol for treatment of a delirium episode in a recent survey. 53% worldwide and 88% of those in the US reported using second-generation antipsychotics for the treatment of a delirium episode. However, although prior guidelines from the American College of Critical Care Medicine suggested the use of antipsychotics for the treatment of delirium, for example, in the 2002 guidelines, haloperidol was considered the preferred agent for the treatment of delirium in critically ill patients. More recent guidelines do not recommend the use of haloperidol or second-generation antipsychotics for the treatment of delirium. They note that there is no evidence to suggest shorter duration of delirium, reduced duration of mechanical ventilation, reduced ICU length of stay, or decreased mortality. Several recent studies have examined the issue of whether antipsychotics treat delirium. One of the most well-known was a study published in the New England Journal in 2018, which compared intravenous haloperidol to intravenous ziprasidone to placebo for patients who were in the intensive care unit. It's important to keep in mind that 89% of the patients in this study had a hypoactive delirium, and that patients received an average of 11 milligrams of haloperidol and 20 milligrams of ziprasidone. The primary endpoint was days alive without delirium or coma, and at the end, there were no major differences in days without delirium between the agents, and no agent was shown to improve survival. There's also been a recent meta-analysis, which is part of a larger yet-to-be-published series, looking at 26 studies, including a variety of antipsychotics like haloperidol and second-generation antipsychotics. The critical outcomes of this study include cognitive function, delirium severity, hospital length of stay, and sedation. And the meta-analysis found no differences for haloperidol and second-generation antipsychotics compared with placebo. No differences between haloperidol and second-generation antipsychotics were found either. Importantly, there was no evidence of neurological harm with any agents in the study. So, in conclusion, antipsychotic medications pretty clearly do not treat delirium. They have not been shown to reduce the length of delirium in any large studies. The only treatment for delirium remains what we've taught medical students and residents for decades, which is to reverse the underlying cause and treat the medical illness. Again, take-home points are that antipsychotics do not treat delirium, but as we'll talk about in the next section, antipsychotics may be very useful if the patient is experiencing significant distress due to symptoms of a delirium, or if they're agitated and at risk of physically harming themselves or others. There are no differences between antipsychotic agents in terms of the treatment of delirium. And again, the only treatment for delirium is to reverse the underlying cause and treat the medical illness. We know already that there are a lot of non-pharmacologic management strategies for delirium that have shown to be effective. These include screening for delirium multiple times a day, generally at every shift, creating a calm, orienting environment for patients using clocks, calendars, familiar objects from home, encouraging normal sleep-wake cycles for patients, which are often challenging in hospital settings, involving family members in supportive care, placing the patient near the nursing station as a means of reorienting them, ensuring that glasses and hearing aids are available to patients, closely monitoring fluid input and output, and a really important one that sometimes gets missed, discontinuing all non-essential medications, or as we like to say at MGH, cleaning the patient up. These non-pharmacologic strategies have sometimes been described as bundles, like the ABCDE bundle, which includes awakening and breathing coordination, delirium prevention and management, and early physical mobility. Experts recommend working directly with nursing around many of these recommendations. If there's a nurse member on the psychiatry consultation team, this can be a particularly great role for that person. In terms of discontinuing medications or cleaning the patient up, be sure to do this in conjunction with the primary team and other consultants so that it's not seen as a battle between specialties. And we have found that education and in-services can go a long way towards helping primary teams understand that delirium is part of their responsibility and not just the responsibility of psychiatry or neurology. So we have several non-pharmacologic strategies to help manage delirium. When thinking about the management of delirium overall, remember to prioritize non-pharmacologic strategies. Can we manage delirium using medications? Well, this is really the big question currently. Anecdotal evidence would say yes. Randomized controlled trials are definitely needed with doses that are practical and outcomes that are able to be measured. I'm going to talk a little bit about the historic use of antipsychotics as a means of managing delirium, and then we're going to dive into specific agents. So antipsychotics have really been the mainstay of delirium management for decades. They're used to manage agitation, and they're used to mitigate perceptual disturbances. Individual psychiatrists will vary in terms of which delirious patients they prescribe antipsychotics to, but most consult psychiatrists would agree that there are two broad groups for whom antipsychotics can be particularly helpful. Those with a hyperactive delirium, in which the antipsychotic is being used to mitigate agitation and decrease the risk of harm to the patient and to staff, and those with significant perceptual disturbances, for whom the antipsychotics may reduce the risk of a post-delirium PTSD. It's important to keep in mind that there's a large group that is not part of those two groups, where patients have a hypoactive delirium without perceptual disturbances, and there's really a lot of disagreement on whether to use antipsychotics in those patients. Some people believe that antipsychotics will still help with some symptoms that those patients might be experiencing, where others feel like the risk of the antipsychotics and the potential side effects probably don't outweigh the benefit in those settings. In terms of the choice of specific agent, in the 80s and 90s, intravenous haloperidol and chlorpromazine were really the two major agents that were used. But in the past 20 years, second-generation antipsychotics have been used with increased frequency to help manage delirium. The choice of antipsychotics often ends up being based on receptor profile, side effects, and really the personal preference of the prescribing or consulting physician. Talking about individual agents, we'll start with intravenous haloperidol. The use of IV haloperidol in delirium dates back to the 1970s. And originally, haloperidol was chosen because it has a very high affinity for D2 receptors with little effect on serotonergic, alpha, histamine, or cholinergic receptors. This is important because it tends to be a relatively clean drug and does not have anticholinergic side effects, which might worsen the delirium. Importantly, haloperidol also acts as a sigma-1 antagonist, though it's unclear what effect that has for delirious patients. Traditionally, the intravenous route of haloperidol was preferred over other routes because it was fast-acting. It avoided the pain and the fear that were often caused by repeated IM injections, and it also avoided a false elevation of creatinine kinase, which may be important if somebody develops symptoms that look potentially like neuroleptic malignant syndrome. IV haloperidol is twice as potent as the oral form, has a faster time to onset, and a long-lasting effect. Very importantly, it is said to be calming but not sedating, meaning that when given by itself, IV haloperidol will not snow the patient or make them unarousable. IV haloperidol is also shown to cause EPS very infrequently and is thought to be far less likely to cause EPS than other forms of haloperidol, including oral and intramuscular varieties. However, keep in mind that intravenous haloperidol does potentiate the sedative effects of other agents. So if it's given in conjunction with a sedating agent or at a time when a sedating agent has been given within the few hours surrounding the use of intravenous haloperidol, that may result in the patient becoming snowed or overly sedated because of the potentiating effects. Typical starting doses are anywhere from 1 to 5 milligrams every 4 to 6 hours, though sometimes reduced doses of less than 1 milligram are used in frail or elderly patients. Prior algorithms suggest doubling the dose every 30 minutes until the patient is calm but not sedated. This is thought to be because, for unclear reasons, the effect of IV haloperidol does not seem to be cumulative. So if you give the patient the same dose repeatedly, they're unlikely to respond more to a subsequent dose than they did to the initial dose. However, if you increase the dose, there seems to be an increased likelihood of response. Once the desired effect is achieved, that dose is usually given as a standing dose 2 to 3 times a day. I think it's important to keep in mind that sometimes the approach of doubling the dose every 30 minutes can lead to doses that seem absurd or seem unlikely to have an effect. We tolerate pretty high doses of haloperidol on our consult service and will sometimes give single doses of up to even 50 milligrams. And while some of our attendings have experienced giving single doses of hundreds of milligrams, we generally stop before we get to that point and recommend that alternative agents be utilized if agitation persists. I want to address one concern that's often brought up with regards to intravenous haloperidol, and that is the potential effect on QT prolongation and torsade. Our group recently completed a systematic review of this issue, and our conclusion is that the concerns about QT prolongation with intravenous haloperidol may be significantly overblown. The current FDA recommendation is for the use of telemetry at all doses of intravenous haloperidol, though this is not commonly done in most hospital settings. However, recent prospective studies indicate that doses up to 20 milligrams are actually not associated with any significant QT prolongation, and those are pretty good randomized placebo-controlled trials. So we have put forth a set of revised recommendations. Our recommendation suggests that no EKG monitoring at all should be required if the total dose is less than 5 milligrams daily and less than 2 other risk factors for QT prolongation or torsade are present. For patients who are getting more than 5 milligrams daily or have 2 or more risk factors, we recommend a baseline EKG and at least one follow-up EKG, preferably 30 to 60 minutes after administration. Most hospitals and most psychiatry consult services are sort of reflexively recommending daily EKGs for patients with intravenous haloperidol. And our review found that this is probably only indicated for patients who receive a total cumulative dose of greater than 25 milligrams of IV haloperidol. And then finally, for the patients receiving the highest dose, doses greater than 100 milligrams, or who are at the highest risk for torsade, those with a QTc properly corrected of over 500 milliseconds, for those patients, we would think about continuous telemetry or alternative agents. Another thing that was really important in our review was a finding that there is really minimal evidence to suggest that any other antipsychotic is actually safer than intravenous haloperidol with regard to QT prolongation. So we often hear that in cases where the QT gets prolonged, we'll switch to quetiapine or switch to olanzapine because that's a little bit safer than intravenous haloperidol. There's really no good evidence to suggest that that's true. And in fact, I would say if there's enough concern about QT prolongation that you want to stop using IV haloperidol, I would recommend using a non-antipsychotic agent for that patient. Switching now to another agent that was traditionally used for delirium, chlorpromazine. Chlorpromazine was also widely used because it was available in an IV form and because it had a wide dose range. Typically, people would start at something like 25 to 50 milligrams every 6 hours, but the dose could be escalated quickly as needed. Another advantage of chlorpromazine is that it tends to cause less extrapyramidal symptoms because it's a lower potency agent. However, its low potency means that it has more significant alpha-1 and anticholinergic effects, and that is tricky to balance in a delirious patient when we know that anticholinergic medications cause or contribute to delirium. Chlorpromazine is more sedating than haloperidol. Sometimes that can be a benefit, but sometimes that can be a risk. And remember that the sedating properties are again due to anticholinergic effects. Finally, keep in mind that chlorpromazine, being a low-potency phenothiazine, is actually associated with a high amount of QT prolongation and a significant risk for torsade when compared to other agents. Low-potency phenothiazines are actually the class that are most represented in cases of QT prolongation or torsade. So chlorpromazine remains a very viable option. It's great because of its availability in IV form and its lower likelihood to cause EPS, but there are a few things that you need to be mindful of when using it. As I mentioned, over the past 2 decades, second generation or atypical antipsychotics have become much more prevalent in terms of their use. They tend to be more sedating, and again, this can sometimes be a good thing in delirium. It can sometimes be a bad thing in delirium. They were originally used because they were felt to be safer in terms of side effects. They were thought to cause less EPS, they were thought to cause less QT prolongation, but these comparisons really don't have robust supporting data. And again, it's important to keep in mind that many atypical antipsychotics have prominent anticholinergic effects, and this is partially what drives their lower potency. Starting with olanzapine, olanzapine is available in dissolvable and intramuscular forms, which increase its ability to be given to a variety of patients. Remember that the intramuscular form does have some concerns if given with benzodiazepines. There are concerns for cardiopulmonary issues, and so you have to be careful about giving IM olanzapine if the patient is also receiving benzodiazepines. Important for psychiatrists to recognize is that in some hospital settings, particularly in emergency rooms, IM olanzapine is starting to be given in the IV form. This is actually similar to the way that IV haloperidol gained traction, where the IM form is just given through the IV. And this is being used in emergency department settings to manage primarily migraine, headache, and nausea, though in some cases it started to be used for agitation. So it's important for psychiatrists to be aware of that growing trend as well. Olanzapine is a low potency agent. It's a dirty drug affecting multiple receptors, and that includes anticholinergic effects, and it tends to be quite sedating. Another drawback of olanzapine is that it has a pretty moderate dose range. So we typically start it for delirium at 2.5 to 5 milligrams every 6 hours, but we don't have a lot of ceiling to go up because the max dose remains about 20 milligrams daily. The QT effects of olanzapine are moderate. So it's in the large group of antipsychotics that are somewhat in the middle. There's older lore that it's safer than other agents, but that really hasn't borne out. And we really can't even say that it's safer than intravenous haloperidol. Another second-generation antipsychotic that is commonly used in delirium is quetiapine. Quetiapine is only available in oral form, but it does have the advantage of having an exceedingly wide dose range. Doses typically start at 25 to 50 milligrams every 6 hours, but doses up to 1,200 milligrams a day are tolerated. It is important to be cautious about increasing doses by more than 100 milligrams a day due to the risk for orthostasis. Again, quetiapine is a drug that interacts at multiple receptors and has prominent antihistaminergic and anticholinergic effects. This makes it more sedating as an agent. Importantly, especially at low doses like 12.5 to 50 milligrams, quetiapine is primarily acting through anticholinergic and antihistaminergic effects. So if we think that the important mechanism of action of an antipsychotic with regards to delirium has to do with dopamine blockade, you're really not getting a lot of that with low-dose quetiapine. It is preferred by neurologists because of the lower likelihood to cause EPS, but it does have an FDA warning about QT prolongation. Probably it's not any different than any of the other drugs sort of in the middle range of QT prolongation, but it's important to keep in mind that it's not fully safe from the standpoint of QT prolongation. So overall, I think quetiapine can be helpful when you're looking for a sedative agent. It can be particularly helpful as a soporific agent in the evenings for delirious patients, but I hesitate to use it for agitation or for perceptual disturbances at low doses because you're really not getting much other than an anticholinergic effect. For patients with a hypoactive delirium who may have prominent perceptual disturbances, another agent that has grown in popularity is aripiprazole. Aripiprazole, unlike many of the other agents we've talked about, is not particularly sedating. So it does not tend to sedate patients or even really calm patients, but it can be great for effects on perceptual disturbances. And though aripiprazole is mostly a low potency agent, it is important to remember that it can cause significant akathisia, and that's something to monitor patients for if you're using it for delirium. It has minimal effects on QT and is probably the safest antipsychotic with regards to QT prolongation. It has a fairly wide dose range. Doses typically start at 1 to 2 milligrams every 6 to 8 hours, but doses up to 30 milligrams a day may be tolerated. With regard to other second-generation agents, ziprasidone is used in some settings, but concerns about QT prolongation remain prominent. And newer agents like lurasidone are occasionally used, but really don't have a lot of evidence or even anecdotal experience at this point. So overall, the choice of antipsychotic should be largely based on target symptoms, medical comorbidities, age, side effect profile, and historical response. If you move towards a pharmacologic strategy to help mitigate agitation or perceptual disturbances, intravenous haloperidol may be a good option because it's fast-acting and it avoids the pain, fear, and elevation of creatinine kinase that is caused by repeated IM injections. Although atypical antipsychotics were originally used to help manage delirium primarily because they were felt to be safer in terms of side effects, these comparisons do not actually have robust supporting data. Quetiapine is preferred by neurologists because of lower rates of EPS, but it's important to keep in mind that at low doses, quetiapine is primarily exerting effects through anticholinergic and antihistaminergic actions. And finally, aripiprazole may be a particularly good strategy for patients with a hypoactive delirium who have prominent perceptual disturbances. Besides antipsychotic agents, there are several other agents that have been used to help manage the sequelae of delirium. One of the most commonly used sets of agents is melatonin and melatonin agonists. These can be helpful in restoring sleep-wake cycle, but they also have important immunomodulatory effects, which may help with the management of delirium. They have a relatively benign safety profile and generally not many concerns associated with their use in delirious patients. We will generally start melatonin in the hospital for any patient with delirium. Another group of agents that has received a lot of attention over the last 5 years are the alpha 2 agonists. We discussed earlier that dexmedetomidine has been associated with reduced rates of delirium compared with other sedatives. Clonidine is another alpha 2 agonist that historically was used in patients with traumatic brain injury for agitation and has more recently been applied as a management strategy in delirium. Clonidine also has some evidence in being used for alcohol and opioid withdrawal and can be particularly helpful for patients suffering a delirium due to one of these etiologies. Finally, there is some very early anecdotal evidence on guanfacine use for delirium, and I expect to see more about that in the coming years. Conveniently, clonidine is available in a long-acting patch form, which makes it relatively easy to dose. Typical doses for delirium start at 0.1 to 0.2 milligrams per day. It's important to keep in mind that all of the alpha 2 agonists, including clonidine, can cause hypotension and bradycardia. Bradycardia is particularly important if you are using other medications that may increase the risk for QT prolongation. Though clonidine and alpha 2 agonists do not themselves increase the risk for QT prolongation, by causing bradycardia, they greatly increase the risk for torsade in patients who already have QT prolongation. Another agent that is commonly employed for delirium in the hospital setting is valproic acid. Traditionally, valproate has been used for impulsivity, agitation, and dysexecutive syndrome in patients with traumatic brain injury or dementia. And more recently, it's been used to help manage delirium as well. There is at least one study that suggests a decreased use of antipsychotics in the setting of using valproic acid in patients with delirium. Valproate has the advantage of being available in an IV form and can be loaded, which is wonderful for rapid titration. It has a wide dose range, though a narrower therapeutic window, and you may not even need to get into the therapeutic window to get effect. Typical doses are started at 250 milligrams 2 to 3 times a day and titrated to effect, but again, it can be loaded for a more rapid effect. It's important to keep in mind that valproate can cause pancreatitis as well as a fulminant hepatic failure, though both are rare, and can also be associated with independent hyperammonemia. So we often recommend checking a baseline ammonia before starting valproate, particularly in hospitalized patients. Another agent that is sometimes used to help manage the sequelae of delirium is trazodone. Trazodone may be useful for anxiety and irritability in addition to its sleep effects, and it can be particularly useful in older patients who, for a variety of reasons, may not be able to tolerate antipsychotic agents. Trazodone is only available in oral form, so patients have to be able to take the pill, but it has a really wide dose range with a starting dose in the hospital of 12.5 to 25 milligrams every 6 hours PRN. But obviously, historically, in antidepressant doses, people got up to 600 to 800 milligrams of trazodone. There is a theoretical risk of priapism with trazodone, though the incidence is low. Key points for this section include the idea that melatonin and melatonin agonists are very useful in restoring the sleep-wake cycle and also have immunomodulatory effects. Dexmedetomidine has been associated with reduced rates of delirium compared with other sedatives, and clonidine may be a good management strategy for delirium as well. Valproic acid can be useful for impulsivity, agitation, and dysexecutive syndrome in both demented and delirious patients. And trazodone may be particularly useful in older patients who cannot tolerate antipsychotics. In this section, we'll talk about some other classes of agents that are sometimes used for delirium, though less commonly. Beta blockers, like propranolol, are occasionally used to manage agitation, specifically in patients with traumatic brain injury. Propranolol is preferred because of its penetrance of the blood-brain barrier. Benzodiazepines have been the source of a lot of controversy over the years with regards to delirium, and the historic lore is that benzos are bad in delirium. However, keep in mind that benzos may be necessary in certain causes of delirium, including alcohol withdrawal, non-convulsive status epilepticus. And low-dose benzodiazepines added to antipsychotics can actually enhance the effects of the antipsychotics and allow for lower dosing of those agents. In fact, a recent meta-analysis suggested that haloperidol and lorazepam may be the ideal combination for managing delirium. When benzos are used in delirious patients, lorazepam is often the go-to benzodiazepine because of its fast onset and moderate duration of action. But it's important to keep in mind that lorazepam, as well as longer-acting benzodiazepines, may build up over time. And particularly when they're being used to manage withdrawal, we occasionally see the phenomenon of patients becoming over-medicated on benzodiazepines or almost intoxicated on benzodiazepines. So I think the lore that benzos are bad in delirium is an important first principle to keep in mind. Another group of agents that have been looked at in delirium over the years is acetylcholinesterase inhibitors. These would be intuitive choices since we think that delirium represents a state of relative anticholinergicity. But the evidence is really mixed. Even in cases of clear anticholinergic poisoning, it's not always the case that anticholinesterase inhibitors help with delirium. Stimulants have also been used at times for hypoactive delirium, particularly for patients with significant apathy. If somebody has a real hypoactive delirium and the delirium is interfering with their ability to participate in PT or OT, you might try using low-dose methylphenidate starting at 5 milligrams daily with a gradual titration by 5 to 10 milligrams daily as a way to mitigate their hypoactive delirium. Stimulants like methylphenidate have mild effects on heart rate and blood pressure. They do carry a risk of worsening psychosis and should be used in caution for anyone showing evidence of perceptual disturbances. Key points for this section include the idea that propranolol can be used to manage agitation in patients with traumatic brain injury. Benzodiazepines, though typically bad in delirium, can occasionally be used at low doses in combination with antipsychotics to help manage delirium. Stimulants may be effective for a hypoactive delirium, particularly if significant apathy is present. We'll switch now to talking about a couple important special considerations in delirium. The first is near and dear to my heart and something that I'm always mindful of, and that is catatonia. Increasingly, catatonia is being recognized in patients with delirium, and there is starting to be described a significant overlap between symptoms of catatonia and symptoms of delirium, particularly in patients with a hypoactive delirium. This causes a significant dilemma when it comes to management because we would typically use benzodiazepines for catatonia, though they can make delirium worse, and we would typically use antipsychotics for delirium, but those can make catatonia worse. An important principle for physicians to keep in mind if they see patients who look both delirious and catatonic is that benzodiazepines are in fact sometimes helpful in this situation, even despite the delirium. So my first choice would usually be to try some intravenous lorazepam to see if the catatonia responds, even if I think the person is delirious. I can then make a decision about where to go from there once I've confirmed whether there is a response to the benzodiazepine. In terms of other agents, the two I would most often go to in this setting are amantadine and memantine. Both have been shown to be helpful in cases of catatonia, and neither will have deleterious effects for a delirious patient. And in fact, memantine may actually have some beneficial effects in delirium. Always remember to use antipsychotics with extreme caution in any patient who looks catatonic due to the risk of precipitating a malignant catatonia. So even if somebody has a prominent delirium, if they have catatonic features, I'm going to shy away from using antipsychotics in that situation. The second special consideration that I want to talk about is one that's on everybody's mind, and that is what do we do for delirious patients who are infected with SARS-CoV-2, the so-called COVID delirium. Delirium, as many of you know, is being frequently described in patients with COVID-19. It's actually now one of the key symptoms and may be a presenting symptom. There's also, interestingly, a syndrome seen in delirious patients with COVID-19 that looks very much like catatonia or akinetic mutism, with abulia, alogia, and rigidity being described. And there are all sorts of hypotheses in terms of why patients with COVID-19 may get delirious, including ideas about a primary delirium, like an encephalitis, or a secondary delirium caused by other systemic effects. We developed an algorithm based on our anecdotal experience early in the course of COVID, and a similar algorithm was independently developed by folks at Stanford, and they align really well. In both algorithms, first-line agents for COVID delirium include melatonin or melatonin agonists, as well as alpha-2 agonists. This is because antipsychotics carry some increased risk in these patients, particularly around EPS, QT prolongation given other medications they may be receiving, and catatonia. And so we want to just move the antipsychotic step back one beat. So generally, we'd start with melatonin, and then we'd start with an alpha-2 agonist. And then if we needed something else, we would typically reach for an antipsychotic. The choice of antipsychotic in the setting of COVID may also be driven by the potential side effects. One agent that we had a lot of experience with early in the pandemic was chlorpromazine, which again is available in IV form. It's low potency, so it carries a lower risk of worsening EPS or causing catatonia. And we found it to be a particularly good choice for patients with a COVID delirium. Interestingly, though, I would also highlight that IV haloperidol is not only useful in COVID delirium, but it's actually being studied as a treatment for COVID, given its sigma effects. Key points in this section include the ideas that catatonia is increasingly recognized in patients with delirium, particularly those of a hypoactive variety. In patients with catatonia and delirium, we would consider first using benzodiazepines, but also using amantadine and memantine. For patients with a COVID delirium, you want to consider using melatonin and alpha-2 agonists prior to using antipsychotics. And in those patients, chlorpromazine may be a particularly good choice for an antipsychotic agent, though other agents like IV haloperidol and second-generation antipsychotics can certainly be used. In the final section, we'll walk through a clinical case vignette that will hopefully help you to consolidate a lot of the knowledge that we've learned today. Our case involves Mr. A 76-year-old male admitted for repair of an abdominal aortic aneurysm with a history of mild cognitive impairment. His past medical history is also notable for hypertension, diabetes, and a prior myocardial infarction. His home medications include carvedilol, atorvastatin, losartan, glipizide, metformin, and diphenhydramine for sleep. His family notes that during a prior admission for surgery, Mr. A had problems with visual hallucinations and tried to leave the hospital several times. Unfortunately, Mr. A has several risk factors for delirium. First, he's an older male, and we know that age conveys increased risk. Secondly, he has a vulnerable substrate. He has a history of mild cognitive impairment. So those are two important non-modifiable risk factors. He also has a significant medical history with several past medical problems, which conveys his risk. And he's being admitted for a very complex surgery that tends to involve a lot of systemic inflammation with very high rates of delirium afterwards. Finally, and maybe most importantly, there's also a suggestion that Mr. A has actually had a prior episode of delirium. And we know that the best predictor of future behavior is past behavior. So patients who have an episode of delirium in the past are more likely to have an episode of delirium in the future. Mr. A also has a modifiable risk factor based on his medication list. He's on multiple medications, but prominent among them is diphenhydramine for sleep. Diphenhydramine is an anticholinergic medication that's known to be associated with high rates of delirium. Given Mr. A's multiple risk factors, what are some things that might be done to reduce his risk of delirium? Well, one thing that we can do early on is clean up his medication list. And in particular, I would think about trying to get rid of the diphenhydramine and replacing it with something like melatonin, which may actually help with delirium and may also help with his sleep-wake cycle. We can't really change his past medical history. We can't change his age. We can't change his vulnerable substrate. We can't change his history of delirium. And we can't really change the fact that he needs an AAA repair done. However, we may be able to mitigate his risk of delirium further by talking with the surgery team ahead of time and preparing them for the likelihood that Mr. A will develop delirium. This may help the team and the nursing staff to recognize signs of delirium early in the course if they emerge, and we may also be able to employ some non-pharmacologic strategies to help mitigate his risk. Things like reorienting him, making sure that family is visiting, those kinds of things. Additionally, we want to think carefully about Mr. A's sedation and choice of analgesia both during and after the surgery. If he's going to require sedation, we might want to advocate for using dexmedetomidine because we know that it's associated with lower rates of delirium. If he requires pain medication, we'll want to think about using agents like Dilaudid and oxycodone and avoiding an agent like morphine. Despite our best efforts, 2 days after surgery, Mr. A reports to his nurse that rodents are crawling all over his room at night. He also attempts multiple times to get out of bed and at one point kicks an aide who is trying to help him. The surgeons would like a recommendation for medication to help with his mental status. How would you make the diagnosis of delirium in this case? Well, we've heard already several clues that point to a delirium. He's having perceptual disturbances where he's seeing rodents in his room. He's intermittently agitated, trying to get out of bed and kicking at staff. Both of those things point to delirium as a potential cause. In order to make the diagnosis, we'd have to check with family and staff to clarify that this does represent a change in his mental status from baseline, that these symptoms are new. We'd want to check with nursing staff to see if there's fluctuation over the course of the day. It sounds like days may be better than nights, which is a common pattern in delirium, but we'd want to confirm that. And then we'd want to do some bedside testing of our own, including a good neurologic exam and some cognitive testing in order to make the diagnosis. What expectations might be helpful to set with the team and Mr. A's family regarding medications? This is a place where conversations and liaison work can be hugely helpful. So we should make it clear to Mr. A's team and his family that we don't have medications that are going to treat his illness. His delirium is the direct result of not only his risk factors, but also the surgery that he just underwent. And it may be that time is really the only thing that is going to reverse the delirium. We want to be practical about what we can offer and what our goals are, but also set clear expectations that the delirium may continue, that it may worsen, and that if we use medications to help manage it, he may have times when his symptoms get worse, and that may cause it to look as though the medications actually worsened his delirium, when in fact that's just the natural fluctuation of the illness. What class of agents or specific medications might be indicated as a first-line strategy? Well, we've already talked about the idea of replacing his Benadryl with melatonin. Given that Mr. A has both prominent perceptual disturbances and episodes of agitation, I would also think about utilizing antipsychotics as a first-line strategy to help mitigate these sequelae. We know that Mr. A has some cardiac risk given his prior myocardial infarction, so I would want to check an EKG before starting medications to make sure that his QTC isn't prolonged. But all other things being equal, I might choose a low-dose intravenous haloperidol or a low-dose atypical antipsychotic as a starting point to mitigate Mr. A's agitation and perceptual disturbances. The patient responds well to PRN doses of intravenous haloperidol, but continues to have intermittent agitation and experience perceptual disturbances. How might we increase the sedative effect of intravenous haloperidol? Well, we talked earlier about a couple of strategies to do this. We know that IV haloperidol by itself is not particularly sedating. However, it does tend to potentiate the sedating effects of other agents. One way to increase the sedative effects would be to give it in conjunction with a low-dose benzodiazepine like 0.25 or 0.5 milligrams of lorazepam. Another possibility would be to mix antipsychotic agents and use haloperidol in conjunction with an atypical antipsychotic, which may be more sedating. This is a strategy that we sometimes use on the consult service, where we'll give the intravenous haloperidol early in the evening, maybe around 6 p.m., as a way to kind of slow the patient down and calm them before bedtime, and then use a low dose of a more sedating agent like quetiapine or olanzapine to help them with sleep overnight. What are some potential drawbacks to this approach? Well, as we talked about earlier, sometimes the ways in which medications achieve sedation may actually worsen the delirium. So using a low-dose benzodiazepine or using an atypical antipsychotic, which has anticholinergic effects, has the theoretical potential to worsen the delirium. Another drawback to the approach is that combining IV haloperidol with a sedating agent may significantly potentiate the sedation and actually snow the patient. And this is sometimes seen when we use these agents in combination overnight, where the patient not only then eventually sleeps at night, but sleeps through most of the day and has challenges restoring their sleep-wake cycle. Later in the course of Mr. A's delirium, the primary team raises concerns about the risk of QT prolongation given his recent surgery. Ultimately, despite your attempts at education, the team decides that they don't want any antipsychotics used because they're too worried about torsade de poids. What other classes of agents or specific agents might you consider? Well, in this case, in an older patient who has a history of mild cognitive impairment and is now delirious after a surgery, I would think about using something like valproic acid to help mitigate the agitation. Valproate isn't going to help with perceptual disturbances, but it may significantly help with impulsivity that we're seeing. Another potential option, if Mr. A is able to take oral medications, would be to use some low-dose trazodone. What are some potential considerations in choosing a specific agent? Well, as always, we want to be mindful about potential side effects. So we haven't really heard anything about Mr. A having risk for liver dysfunction or pancreatitis, but we want to make sure those things aren't true before giving him valproic acid. With trazodone, the risks are relatively low, but we also want to think about potential risks of that medication as well. Key points for this section include the fact that it's really important to take into account all of a patient's risk factors for delirium. It's also important to set reasonable expectations with the medical team and the patient's family regarding medications that can be used for delirium, and also regarding the role of psychiatry in managing delirium. Finally, we want to choose our medications wisely according to the specific patient scenario as well as potential side effects that may occur. So to summarize the key important points that we've learned today, delirium is a syndrome rather than a specific diagnosis, and it represents a constellation of symptoms that are suggestive of global brain dysfunction. It is vastly underdetected across clinical settings, with up to 86% of cases missed. We can divide delirium into different motoric subtypes, with hypoactive delirium being the most prevalent, and this is often confused with depression. Consequences of delirium include increased mortality and morbidity. The only treatment for delirium is to reverse the underlying causes and treat the medical illness. We can apply non-pharmacologic management strategies for delirium, and these include orienting patients, restoring the sleep-wake cycle, correcting dehydration and electrolyte abnormalities, discontinuing non-essential medications or cleaning the patient up, and correcting sensory deficits. The prophylactic use of antipsychotics to prevent delirium is not currently supported by the literature. Antipsychotic agents do not treat delirium. A 2019 network meta-analysis found that Ramelteon was the most effective agent at preventing delirium. When we think about specific agents for managing delirium, intravenous haloperidol is one preferred agent due to the fact that it is fast-acting and avoids the pain and fear associated with repeated IM injections. It's twice as potent as the oral form, has a faster time to onset, and a long-lasting effect. IV haloperidol is calming but not sedating. Concerns about QT prolongation with IV haloperidol may be overblown. Atypical antipsychotic agents as a class tend to be more sedating. They were historically thought to cause less EPS, but in reality, the rates may not be much different than those with intravenous haloperidol. There does not appear to be a difference between intravenous haloperidol and most atypical antipsychotic agents in terms of the risk of QT prolongation. Melatonin and melatonin agonists can be very useful in restoring the sleep-wake cycle. They have a relatively benign safety profile and may also help in delirium due to immunomodulatory effects. Alpha-2 agonists can also be used for delirium. Dexmedetomidine has been shown to have decreased rates of delirium when used, and clonidine is another agent that may be used for management. All alpha-2 agonists can cause hypotension and bradycardia. Propranolol is a beta blocker that is occasionally used to manage agitation, specifically in patients with traumatic brain injury. Valproic acid can be used for impulsivity, agitation, and dysexecutive syndrome in patients with delirium. It's available IV and can be loaded for rapid titration. Trazodone may be helpful in delirium, specifically for older patients with anxiety and irritability who may not be able to tolerate antipsychotics. Acetylcholinesterase inhibitors have mixed evidence in terms of their use in delirium, even in cases of clear anticholinergic poisoning. Stimulants are used at times for hypoactive delirium, especially when significant apathy is present. Generally, methylphenidate is used at a dose of 5 milligrams daily to start, with gradual titration of 5 to 10 milligrams daily. Though benzodiazepines are considered bad for delirium, low-dose benzos added to antipsychotics can occasionally enhance the effects of those antipsychotics and allow for lower doses. A recent meta-analysis suggests that haloperidol and lorazepam in combination may be ideal for managing delirium. It's important to keep in mind that catatonia can overlap with delirium, particularly hypoactive delirium, and that benzodiazepines are sometimes helpful in that case, even despite the delirium. Other agents to consider are amantadine and memantine. Please use antipsychotics with caution in any patient who appears to have symptoms of catatonia due to the risk of precipitating malignant catatonia. And in patients with a COVID delirium, melatonin and alpha-2 agonists should be used prior to antipsychotic agents. However, antipsychotic agents can be quite useful in this setting, and chlorpromazine may be a particularly good choice.